Hello and welcome to the SRNA Ask the Expert podcast series. I'm Krissy Dilger with the Siegel Rare Neuroimmune Association. For this episode, Paraneoplastic Diseases and Rare Neuroimmune Disorders, I am pleased to be joined by Dr. Shailee Shah. Dr. Shah is a neuroimmunologist and clinical assistant professor of neurology at Northwestern Medicine. You can find her full bio in the podcast description. SRNA is a nonprofit focused on support, education, and research of rare neuroimmune disorders. You can learn more about us on our website at wearesrna.org. This episode is made possible in part by the generous support of Amgen, Alexion AstraZeneca Rare Disease, and Genentech. Hi, Dr. Shah. Thank you so much for joining us today. To start off, can you explain what is paraneoplastic disease and how does it affect the nervous system?
Yeah, thank you for having me. So, paraneoplastic neurologic syndromes are essentially thought to be these remote effects of cancers where we have this sort of off target immune mediated process that adversely affects the brain or the nervous system as a whole. So, that can really be any part of the nervous system, whether that's the brain, the spinal cord, the peripheral nerves. And these diseases are quite heterogeneous and can be difficult to diagnose, but are associated very commonly with an underlying cancer. And as autoimmune neurologists, we actually have established paraneoplastic neurologic syndrome diagnostic criteria. In the early 2000s, there was originally a criteria that was developed, but since that time, we've identified so many new autoantibodies, which we think are either biomarkers of this underlying paraneoplastic process or directly responsible for, depending on the particular target. And so, with the identification of all of these novel autoantibodies in association with various clinical syndromes and malignancy types, there has been a need to develop a new criteria. And around 2020, 2021 or so, a new clinical criteria for paraneoplastic syndromes was identified. And this essentially developed a scoring system that incorporated a number of different factors that are thought to be important in making this diagnosis more readily accessible to neurology providers, whether you are an autoimmune neurologist specifically or a general neurologist practicing in the community. It really allows for people to assess whether someone is at high risk of having one of these syndromes. And what it does is it uses a subset of certain autoantibodies and categorizes them as either high risk or otherwise. And it also categorizes certain tumors as being more likely to be associated with the paraneoplastic syndrome, things like small cell lung cancer, neuroendocrine tumors in general. And then also combines that with specific neurologic phenotypes, which we think are most commonly occurring in this context. And some of the most common paraneoplastic phenotypes that we see, while they can overlap with other diseases, are things like limbic encephalitis, brainstem encephalitis, as well as a progressive cerebellar syndrome. There are others, including encephalomyelitis and different types of neuropathies, like a sensory neuropathy or neuronopathy, or even a more diffuse polyradicular neuropathy. And so, while these are just some of the many different phenotypes that have been described with paraneoplastic diseases, there are quite a few others as well, many of which are quite rare. And recognizing these is really important in order to quickly be clued into the possibility that somebody might have an underlying cancer causing these syndromes. This can be really particularly challenging in patients in whom a cancer has not yet been identified, because at that point, the workup is still quite broad. We're thinking about neoplastic causes still. We're thinking about toxicities and other causes of neurologic diseases like vascular causes or primary or diseases that are neurodegenerative in nature. In patients who already have a cancer, which is also a considerable subset of patients who have paraneoplastic syndrome, where the tumor actually is known and then a patient begins to experience neurologic symptoms, you have a very different differential diagnosis, which is in many ways equally challenging, because in these patients, you also have to consider the possibility that this is direct tumor infiltration, this is a side effect of chemotherapy, perhaps an infection because the patient is immunocompromised as a result of the chemotherapy that they're receiving. Many of these patients can have a lot of disability and just overall malaise as a result of the cancer therapies, and sometimes that can look like a neurologic disease. And then most importantly, but there are now a class of medications that are being used for cancers called immune checkpoint inhibitors, which in short will harness the body's own immune system to help attack the cancer and have been shown to improve survival and mortality in patients with multiple malignancies. The number of indications for these drugs is continuing to grow. And what we're finding is that when we activate the immune system in order to treat a cancer, there is this off-target risk of developing an autoimmune process that can be outside of the neurologic system, but also within the neurologic system. And so these immune-related adverse events from immune checkpoint inhibitors are now well understood and sit in parallel with our conventional paraneoplastic neurologic syndromes. The difference between those and what we classically associate as paraneoplastic is that there does seem to be a difference in the type of autoantibodies that are associated with certain cancers, and there does seem to be a difference in the phenotypes that we're seeing. And so we have all these rules that we've established with the paraneoplastic neurologic syndrome criteria, but what we're finding is that when we use these immune checkpoint inhibitors, those rules seem to break down to some extent.
Thank you so much for that explanation. That is really interesting, and I'm excited to learn more throughout our conversation. How are paraneoplastic diseases different from other autoimmune or neuroimmune disorders?
And so I think we touched on this a little bit, but paraneoplastic diseases are thought to specifically be related to immune-mediated processes that are occurring often in the context of a systemic neoplasm. The thought is that there are a number of different neuronal nuclear or cytoplasmic or cell surface autoantibodies that have now been identified, and that some of these, in particular the nuclear cytoplasmic autoantibodies, are more likely to be identified in patients who have these paraneoplastic syndromes, again, most commonly associated with tumors. This is in contrast with some of the other autoimmune neurologic diseases we see, where the cell surface autoantibodies tend to be more readily identified in those patients. There tends to be a lot of overlap between the type of phenotypes that we see, but there are some sort of distinct differences between those antibody types. And so when we're talking about paraneoplastic intracellular autoantibodies, I mentioned that they're found in these diseases, but it's not entirely clear based on our understood pathophysiology that these are directly responsible for the disease that's occurring or for the damage that's occurring to the neurons in the context of this disorder. That's in contrast with these cell surface autoantibodies, in which We think there is this direct B cell activation that's developing, these autoantibodies are being developed, and these are directly pathogenic, causing either complement or antibody dependent cellular cytotoxicity.
Got it. Thank you. Can you go into how common paraneoplastic diseases are? I know you mentioned that there are some that are more rare than others, but as a whole, how common are they?
Yeah. So paraneoplastic diseases, which we really mostly at this point define by the presence of an autoantibody, and so bearing in mind that there may be some that have not yet been fully identified or that we have not as great of an understanding of them or their relationship with the cancer. They are generally, though, considered to be rare diseases. And so there have been a number of studies across the world looking at their prevalence and their incidence. And they probably are, we think of it as almost 5 per 100,000 people approximately have a paraneoplastic disease at any given time. And that's people that are just living with these diseases. Now, still quite rare. That might be somewhat analogous to, say, a disease like ALS, and is very different from something like multiple sclerosis, which is much more common. Um, but even that number, 5 per 100,000, is a lot more than I think what was originally thought to be the case. And so, certainly a disease in which we think dedicated care and evaluation is really important at this point in time. We also have some data about autoimmune diseases, neurologic diseases in general, and those are probably, as a whole, about twice as common as just a paraneoplastic syndrome itself. Um, when we also think about the impact of these diseases, you can also think about them in terms of not only how common they are, but also in terms of their impact on morbidity and mortality. And what we find is that these are really disabling conditions. They really have an impact not only on disability, but also dramatically impact a patient's lifespan. And so there are a lot of really long-term important consequences to these diseases that warrant dedicated evaluations and treatments and kind of a better understanding of these diseases.
Very interesting. Thank you. So, what are the most common early symptoms of paraneoplastic disease patients should be aware of?
Yeah. So that can be a really tough question to answer. I think if you split it into two main categories right now, so those patients who don't have a known cancer and those who do, you can start broadly from there. In patients in whom there is not a known cancer diagnosis, in general, we're talking about the subacute onset of new symptoms, subacute meaning symptoms that develop over weeks, sometimes months. That's not always the case. There are exceptions where patients can progress more slowly or a little bit more rapidly. And so this generally speaking, subacute onset of symptoms that develops, it can be one clue to the diagnosis. That's like in contrast with a stroke, which comes on rather abruptly, or a neurodegenerative disease, which, like Alzheimer's, which will develop really slowly over several years. So they sit somewhere in the middle. And so the actual symptoms that a patient can have can vary quite dramatically. I mentioned earlier that there's criteria that now exist, but we have, and in that we talk about and we have this understanding of what specific symptoms actually are more likely to occur in these paraneoplastic diseases. And so, there are some types of symptoms, in particular, progressive cerebellar ataxia or progressive imbalance, trouble with coordination and walking or eye movements that can develop. There are also a number of other symptoms, though. So limbic encephalitis was one I mentioned before. That's where there's inflammation in the temporal lobes of the brain. These are areas that are responsible for and can cause issues with memory and language and behavior and mood. And so, the symptoms can kind of vary depending on the type of presentation a patient has. Certainly, like I said, that ataxia is a common symptom, limbic encephalitis, those changes in memory, behavior, mood. And in addition to that, the presence of seizures can be a common symptom. I also mentioned a sort of a brainstem encephalitis. So if a patient presents with something like brainstem encephalitis, they may develop new onset of double vision or trouble with their speech or swallowing, weakness in their face. And so really it's quite diverse in the type of symptoms that can develop. Many of those overlap with many other diseases. It's really those other sort of clues surrounding the way those symptoms develop that are important. And so I mentioned one of those being that subacute onset, sometimes the presence of multiple areas being involved. So maybe incoordination plus seizures can also be a clue that there's multiple areas involved, which we sometimes more commonly see in these paraneoplastic autoimmune conditions. If somebody also has perhaps other sort of what we call constitutional symptoms, meaning a dramatic weight loss that's happening at the same time, new fevers, night sweats, those can also be clues. And while not always present, can be helpful. Other things is people who have sort of risk factors or known risk factors for a paraneoplastic process or cancer that may develop. So these are patients with perhaps a really long history of tobacco use. And so that might be a patient in whom you're more suspicious or worried that they're going to develop or they are developing something potentially paraneoplastic.
Got it. When should someone seek urgent medical care for neurological symptoms?
I think when we're talking about autoimmune or paraneoplastic syndromes, I think when patients are coming in with really rather abrupt onset of symptoms, which is less common, these are patients who are usually coming into the emergency room. But really, I think if patients are noticing that they're having a number of symptoms developing over several days, weeks, this isn't somebody who has already been to an emergency room. I think that if you're noticing a change over time, then that should be an indication to you to be seen sooner rather than later as a patient. And so sometimes that starts as just going and seeing your primary care doctor to try to get a referral to a neurologist. But depending on where you're located, it might be that just you can get in to see a neurologist rather quickly to have these symptoms evaluated. I think the most important thing is that these patients should be evaluated as quickly as possible, because the quicker we recognize these symptoms and the quicker we identify a potential underlying cause like a tumor, the faster we're able to treat that underlying cause, that underlying cancer. And then we think the better able we are to stop the symptoms from progressing or disability from getting worse.
Good insight. So thank you for sharing. We talked a little bit already about like the clinical guidelines and how these syndromes or diseases are diagnosed, but can you walk me through how a patient presenting with these symptoms might be diagnosed from onset? What types of tests are typically involved? Are there blood tests, spinal fluid, etc.?
Yeah. So, there are a number of different tests that these patients usually get. And I think one of the first tests that patients get is an MRI of the brain. And so that's going to be really quite informative early on, telling us about whether like I said, something like the temporal lobes are involved, or if we have something like the brainstem or the cerebellum that is abnormal. Now, I say this, but actually taking a step back, I think probably the most important test is actually the neurologic evaluation and the exam itself. So I feel like I would be remiss to not mention that explicitly, because the evaluation by a good neurologist is quite possibly the most important thing. So first, recognizing that there are those abnormal signs on exam is going to be important, because testing in these paraneoplastic diseases is quite variable. It really depends on what part of the body or what part of the neuroaxis you actually think is involved. That's going to guide what your next test is going to be. Sometimes it's not an MRI of the brain. Sometimes that first test is actually an EMG or a nerve conduction study specifically. And so probably the neurologic examination is the most important test up front. And then from there, like I said, you're ordering things most commonly like an MRI of the brain, or sometimes if you're worried about a neuropathy, an EMG. If you think a patient might have seizures, you might try to characterize that better by getting something called an EEG. And number of different tests that can be potentially done for a patient. There are a number of blood tests, and there are also a number of spinal fluid tests as well. When we're talking about blood tests, we're usually looking for mimics. We're looking for things that we know are readily identified that can cause neurologic diseases that are easy to test for in the blood. Sometimes that's infectious mimics, sometimes that's, vitamins that are low. Once we've done those tests and excluded those things, we think about some of these more rare and complex disorders. And so that's when we start to do tests for potentially underlying cancers. And then most importantly, autoantibody testing. So panels of antibodies that are usually directed or designed in such a way that they are specific to a particular phenotype, meaning a number of different autoantibodies that we think cause limbic encephalitis, or antibodies that cause a movement disorder, for example. And so these panels, which can be sent to a number of different labs in the country, will oftentimes be sent. And there are tools that you can use, again, that PNS score, but a lot of different ways by which providers can figure out who really needs these panels and tests done, usually sooner rather than later. And so we often send those off in the blood. Now, in general, if you're worried that somebody has a paraneoplastic disease, you should also be sending that test in the spinal fluid. Most of these patients are often getting a lumbar puncture, which kind of entails removal of the cerebrospinal fluid and testing of that for those same antibodies, and sometimes some additional markers of inflammation that are really specific to the spinal fluid, like the white blood cell counts or the protein, or the what we call oligoclonal bands, sort of these markers that help give us a clue as to what the diagnosis could be, or point us in the direction of something autoimmune or paraneoplastic. When doing these tests, almost always we really think it's important that patients get tested in both the blood and the cerebrospinal fluid if we're really concerned about one of these diseases. And that's largely because the actual value of the test and the particular antibodies does somewhat vary between whether it's being tested in the blood or the spinal fluid. So sometimes you're going to detect it more in the blood, sometimes you're going to detect it more in the spinal fluid. We think by combining both of those tests, we're maximizing our chances of finding something that's relevant and important to that patient's disease.
Got it. Thank you so much for explaining that. Can paraneoplastic disease cause myelitis?
Yeah, so paraneoplastic diseases can absolutely cause a myelitis. That is one of the phenotypes that can develop that we haven't really yet talked about. And importantly, that myelitis or that phenotype can develop in conjunction with one of these other phenotypes, or it can develop all on its own. And so that could be something just like a paraneoplastic myelopathy or a paraneoplastic myeloneuropathy. And there are sort of very sort of specific signs or symptoms of that myelopathy or the spinal cord involvement that happens with paraneoplastic diseases. I mentioned earlier that subacute onset is really quite important for diagnosing these, and that remains true for patients who have a paraneoplastic myelopathy. So the vast majority of these patients will come in with sort of a subacute weeks to months of onset of progressive weakness or numbness, spasticity, or tightness of the muscles that occasionally can happen more rapidly or more slowly. This typically happens in older adults and does have some very distinct characteristics that separate it from other diseases that affect the spinal cord. And so, for example, we do see certain markers of inflammation in the spinal fluid when we test that in these patients. We do see that the MRI oftentimes will have very specific types of abnormalities. For example, patients will often have what we call tract specific changes. So, really sort of long areas of the spinal cord that are involved or affected. And also we will frequently see very specific types of antibodies that are associated with these myelopathies or spinal cord diseases. I haven't mentioned any of the specific antibodies yet, but things like CRIMP5 antibodies, which can be associated with, for example, small cell lung cancer, as well as amphisicin autoantibodies, which can be seen with breast cancer, are some of the common autoantibodies that we will see in association with these paraneoplastic myelopathies. I will say that because I think that they sort of sit a little bit separately, but there is this idea that or concept that patients who have neuromyelitis optica or NMO may, when presenting later in life, need to also be evaluated for an underlying cancer. And so we talk about your conventional paraneoplastic myelopathies. There is probably a subset of patients with NMO, those A2P4 positive patients in particular, who should also probably be tested for an underlying tumor. Usually that's older individuals or refractory disease.
Very interesting. I had not heard that before, so I am glad you shared. How long does diagnosis usually take, and what can cause it to be delayed?
Yeah. So I think in general, the cancer diagnosis, if associated with cancer, is often comes after somebody develops the spinal cord disease. And that can take months. It can be a couple months, but it can actually even be a couple years. Sometimes this neurologic disease itself can be hard to identify. Usually that delay in evaluation or that delay in diagnosis comes from essentially sort of a consideration of alternative diagnoses or a lack of early presentation. And so, you know, with the growth of this field having happened so rapidly in the past 20 years, it's become sort of increasingly apparent that considering some of these diseases early on is important, particularly when patients are presenting with some of these more unusual features that we're talking about, the subacute onset and tract specific findings when we're talking about myelopathy specifically, because they think delaying antibody testing or delaying a cerebrospinal fluid evaluation or the appropriate MRIs, in this case of the spinal cord, can lead to delays in diagnosis.
So, should patients seek care at specialized centers or see specialists with specific experience?
Yeah, I think that in the past 20 years, as I mentioned, there's been this growth in this field of autoimmune neurology and our understanding of these paraneoplastic diseases. Increasingly, centers now have individuals who have more specific training and focus on these disorders. And so I do think it's really, really very appropriate for patients to be referred early on to either a specialized autoimmune neurologist or a specialized paraneoplastic clinic. Uh, and then, and that can be either from a primary care doctor or even from another neurologist. Typically, these are centers that will work really closely with patients and their local providers to try to formulate a plan, really sort of multidisciplinary in nature, working with many other people, either, like I said, primary doctors, internal medicine specialists, but also if a cancer is identified, working really closely with oncologists. And so, I think there is value in having somebody like that who can really help facilitate an expedited evaluation. I know that for us at Northwestern specifically, we have a dedicated NMO clinic, and we have a dedicated paraneoplastic neurologic disease clinic. And that really, I think, presents itself as a great opportunity for our colleagues to get these patients in quickly. And not only do the patients get better care, but I think that everybody who's involved in that patient's care is also really learning about what this field looks like. And that really helps all future patients too.
Great. Thank you. So we know, as you've mentioned, that paraneoplastic diseases have an association to cancer. Can you speak more about this association, and does everyone with a paraneoplastic disease have cancer, and what does the treating of the underlying cancer affect the neurological symptoms?
Yeah. Yeah. So once a paraneoplastic disease has been identified, we're oftentimes looking for an underlying cancer. Now, some autoantibodies are more likely to be associated with cancers than others. And we think of these highest risk ones as being associated with cancer up to 70% of the time. That being said, in patients in whom we, early on don't find a cancer, we're oftentimes doing regular screening every 6 months to a year for a couple of years, making sure that this isn't a patient who's going to develop a cancer. And so when we do treat these patients, we're thinking about treatment from both an oncologic and a neurologic perspective. In general, it seems that treating both is really important for maximizing outcomes, but a lot of that is retrospective. We're still kind of learning the best way forward, but we think that one, aggressively treating the underlying cancer is going to be important. Say it's small cell lung cancer, that may be a combination of surgery or radiation or conventional chemotherapy. Sometimes now these immune checkpoint inhibitors or immune oncologic therapies that need to be also factored into treatment decisions. That's one element, and that's usually run and led by the oncologist. And they're coordinating with the neurologist because at the same time, we're oftentimes trying to treat the symptoms that the patient already has. And in general, our goal, once we've identified somebody's disease as paraneoplastic or autoimmune, is to really try to stabilize and prevent further disability. We also hope to try to achieve some improvements, but that's sort of less consistently the case. And so we're usually using immunosuppressive treatments simultaneously early on. So in the acute stages, we're talking about treatments like steroids, things like IVIG or IV immunoglobulins, plasma exchange. These are all treatments that can rapidly shift the immune system, rapidly remove some of those bad autoantibodies or immune cells that we think are causing that neurologic disease. From there, these patients will be put on more chronic long-term treatments depending on how they're doing or sort of depending on the underlying cancer tumor itself. And so that might be some combination of, say, oral steroids in addition to more long-term immunosuppressive treatments. And so there are a number of different drugs. They're all sort of, many of them are repurposed from sort of the oncology or the rheumatology or autoimmune worlds. There actually aren't many new drugs. Most of these, like I said, are old or repurposed. Things like cyclophosphamide or rituximab. Every once in a while, we're using drugs that target something called interleukin 6 or its receptor. And so, those are treatments that we think help suppress the immune system in a longer term capacity. And we'll have to do that oftentimes in combination or even after a patient has been treated for the underlying cancer. We think treating the cancer to some extent will mostly eradicate that disease process, but we do see cases in which the disease can persist or continue on, or that there's this sort of memory in terms of the immune system that outlives that cancer itself. And so that combination is very important. Now, this is an area in which I think we have a lot of work to do, and we really need to really start to better understand who it is that's actually going to be getting these syndromes and developing toxicity, for example, from immune checkpoint inhibitors. And then really from there, maybe more specifically targeting these neurologic syndromes or having dedicated treatment options for them to really maximize their chances of recovery from both the neurologic and oncologic perspective.
It's really interesting, and it seems like an area where there will be a lot of research and changes to come, hopefully, so that therapies can improve and outcomes can hopefully improve as well.
Yeah.
How do doctors decide when to escalate or change therapies?
Yeah, that's a good question. I think that when we're talking about a paraneoplastic disease, it's usually either worsening or breakthrough that will lead to reconsideration of a treatment. It may be that a patient has a period of stability and then starts to show signs of disease again. Importantly, when these scenarios happen, we're really looking for objective changes, either new seizures or something that really can be identified and tracked. And also, importantly, we're looking for that because there may be implications as far as whether or not they need to be evaluated for cancer again. Could they have a recurrent tumor or recurrent cancer that has led to the reemergence of their symptoms?
Got it. So, I know you touched on prognosis and like long-term therapies and recovery, but what would you say recovery typically looks like for patients who have myelitis caused by paraneoplastic disease or syndromes?
Yeah. I think that even so, if you look at a lot of the literature, a lot of it is a little bit, and I say older, not really old, but even 10 to 15 years ago, you're seeing that, up to 50% of patients are wheelchair bound, and a lot of them are actually not doing well. Many of them are dying either from the complications of the neurologic disease or the cancer itself. In general, very few are improving with treatment. I'd like to think that just from like rapid recognition in the past, in that time or since those papers came out, that we are able to, one, identify these patients much sooner, and then two, treat them much more quickly, and seeing patients then not be as disabled in the long run, or potentially catching them at a point in which there may be some reversibility to their symptoms, at least some of them. And so I don't have I wish I had a better answer for you, but I think that this is something that we're actively working to change, which is getting these patients treated quickly and have better outcomes in the long run.
So, what do you wish every patient knew when they were first diagnosed with one of these syndromes?
Yeah, I think that when a patient is diagnosed with a antibody mediated neurologic disease, whether they realize it at that point or not, I think one, they should be aware that there might be a potential underlying cancer. And so looking for that cancer is going to be really important. Importantly, they can make sure that they're up to date on all of their age appropriate cancer screening. But also, I think that helps embolden them to advocate for themselves and make sure that they're getting the appropriate testing early on to make sure that there isn't something that's being missed. I also think another kind of thing that would be really important for them to know early on is that we now do have these paraneoplastic or autoimmune disease experts and centers. And so knowing that early on, and again, being able to advocate for yourself may be really important. Now, it may be that patients are getting excellent care regardless. That's often the case. But I think having a second set of eyes on a rare disease or wanting to see if there are other options or research that is being done may be really helpful for patients.
Great, thank you. And I always like to end on a positive note. So, what gives you the most hope in treating these conditions today?
I think it's the fact that so much has changed so dramatically, and we've already seen so many successes in the field of autoimmune neurology. We've seen diseases identified and then treatments developed within the span of 10, 15, 20 years. And so people are now seeing these diseases, they're seeing their impact, they know this is important. And I think that makes a lot of people more engaged and want to really see a better future for these patients. So I think that's why there are now people who are really trying to do more research and people like my mentors who started this field, who then have spread that knowledge to so many other people, have led to this growth that I think is really going to long term help patients.
Awesome. Thank you so much for joining me today. That is the end of my questions, and we're grateful to have an expert to explain this to us, and I hope to continue the conversation as well when new research comes out and hopefully more is known.
Yeah. Thank you so much for having me.
Thank you to our Ask the Expert sponsors, Amgen, Alexion AstraZeneca Rare Disease, and Genentech. Amgen is focused on the discovery, development, and commercialization of medicines that address critical needs for people impacted by rare, autoimmune, and severe inflammatory diseases. They apply scientific expertise and courage to bring clinically meaningful therapies to patients. Amgen believes science and compassion must work together to transform lives. Alexion AstraZeneca Rare Disease is a global biopharmaceutical company focused on serving patients with severe and rare disorders through the innovation, development, and commercialization of life-transforming therapeutic products. Their goal is to deliver medical breakthroughs where none currently exist, and they are committed to ensuring that patient perspective and community engagement are always at the forefront of their work. Founded more than 40 years ago, Genentech is a leading biotechnology company that discovers, develops, manufactures, and commercializes medicines to treat patients with serious and life-threatening medical conditions. The company, a member of the Roche Group, has headquarters in South San Francisco, California. For additional information about the company, please visit www.gene.com.